Okay, for this next portion, I want to talk about what should we do next if our first attempt at treating depression doesn't work, which unfortunately is really all too common of a problem. There was an attempt to answer this question now about 20 years ago. So you might be thinking, well, why is he talking about 20-year-old data? And the reason why is because this study, which was known as STAR-D or sequential treatment approaches to remission in depression, has never really been replicated in the same way. This was a big effort. It was done by the National Institutes of Mental Health, so it wasn't run by a drug company. And it really attempted to sort of mimic real life practice. So in this study, the way it worked is that they enrolled a lot of people who had depression. So they had 2,800 people in this study, massive study. Everyone had major depression. Everyone got citalopram, Celexa, at the beginning of the study. And the way this worked is if you got better, you got out. And so it was this sort of funnel phenomenon of people. The longer people stayed in the study, the more kind of resistant they were to the treatments that were being given. And if you didn't get better, you either were switched or you were augmented. So in that way, it really kind of replicated real life practice, but in a kind of a more systemic way to kind of study the effects of each level of treatment. But let's go ahead and walk through it. So the people that got better on citalopram on average did so on a dose around 40 milligrams. So that's pretty similar in clinical practice. And about 28% of people went into remission. So good on them, close to a third of people getting better on the first dose, first thing they were treated with. That's a good group to be in. That's really the group you want to be in if you're dealing with depression and you're in this and you're getting treatment like this. Of the people that uh, did not get fully better, they had two options. They could either switch to a new medication. So in this case, the three options for switching were sertraline, venlafaxine or Fexer, bupropion, Wellbutrin. Back then, the XL wasn't I don't think it was available yet. So they used sustained release. And you can see the doses that people, if they did remit, were the average dose that people remitted on. So a little over 100 milligrams of sertraline, close to 200 milligrams of venlafaxine, and close to 300 milligrams of bupropion. And the remission rate among the people who switched was roughly the same. So again, around 25% of people remitted after being switched to a new medication. So, it's good. This is second line treatment. The other option you could have would be to augment. So two common augmentation strategies that were utilized in STAR-D were to either add bupropion instead of switching to bupropion monotherapy. This was bupropion augmentation, or adding buspirone, which is a serotonin 1A partial agonist. In both cases, about the same, about 30% of people got better with augmentation, and you can see the doses at which that was accomplished. So again, close to 300 milligrams of bupropion, about 40 milligrams of buspirone was what did the trick. So now we can start seeing. So this was there's 1,400 people in this level. So now we take out these people that are remitted, and we move on to level 3. So this is a smaller group. This is only 377 people. So we're now at stage level 3. And you had the choice between switching again to either nortriptyline, so a tricyclic antidepressant, largely a noradrenergic agent, or going on to mirtazapine, which is a atypical antidepressant that has effects on norepinephrine and blocks the serotonin receptor. So in this case, again, you start seeing what you're noticing probably here is there's a diminishing of returns. And so we went from, say, about 30% of people getting well at the first stage to about 20, 25%. Now we're dropping down into the teens of people getting well at the third level from switching. But again, similar rates between either nortriptyline or mirtazapine switching, both in terms of remission and in terms of adverse effects. Or you could further augment. And the augmentation offerings that were given here were either lithium or T3, which is cytomel. So you might be thinking, oh, lithium, I've only ever heard of that in bipolar disorder. And that's where most people are familiar with it. But lithium has a long history of being used as an augmentation strategy in unipolar major depression. So in this case, people on lithium were around 900 milligrams. people on T3 are around 45 milligrams. And the outcomes were a little more likely to you're more likely to go into remission from the cytomel than you were lithium, um, and lithium was a little less tolerable. But lithium is still a good augmentation strategy for depression. It's certainly worth a try. And then finally, the unfortunate 142 people who had still not gotten better after 3 rounds of treatment were they were randomized to either tranylcypromine, which is an MAO inhibitor, or a combination of mirtazapine plus venlafaxine. And again, you can see really diminishing returns. So the MAOI folks, only about 7% got better, and the mirtazapine plus venlafaxine, only about 14% got better. Now, one could make an argument that what you really have here is a really concentrated dose of depression. So these are people that probably by definition have a different kind of illness than people that just get better with the first level of treatment. So these are going to be people that are increasingly harder to treat. And unfortunately, the statistical reality is if somebody has been on, say, 10 different antidepressants, the probability of the 11th antidepressant being the one that makes the difference is fairly low. And this is where it's encouraging to have non-monoamine based treatments now, such as ketamine, or looking at procedural treatments such as repetitive transcranial magnetic stimulation as things to offer patients, things that don't necessarily continue repeating the same theme of manipulating monoamines as we did in STAR-D. And one of the big questions that we don't really have a good answer for right now is at what point should we switch to one of those treatments? Should we keep going? Should ketamine be the sixth or seventh thing that we try, or should it be the second or third? And I think that remains a very open question. But one of the things that we want to try and avoid with patients is allowing people to remain sick for longer than they need to be, because unfortunately, one of the things that we know about psychiatric conditions is we tend to get good at what our brain does a lot of. And so if we've had depression for a long period of time, it makes it that much harder to get somebody well. So there's a lot of value in getting somebody well early on so that they don't develop this kind of recalcitrant depression that we saw in the folks that were in the 4th phase of STAR-D. So one of the things that we want to make sure that we're doing before we assume it's treatment-resistant depression, that's what TRD is first of all, are they taking the medication? Because, sometimes we're under the assumption they're taking the medication when they're actually not. So we can't really say they're resistant to it if they haven't taken it. And then the other thing is to make sure that you've actually got the right diagnosis. So, sometimes when it turns out somebody's not responding to an antidepressant, there may be other stuff going on, such as substance use disorders, or maybe there's trauma that isn't being addressed, or maybe the person is in a circumstance, say at home, where they're being harmed. There may be other stuff going on. And so we really want to take a step back and really reassess what we've been the assumptions we've been operating under. Make sure that we are not treating the wrong thing. Now, if you are going to augment, let's take a look at these in detail. So bupropion we talked about in the last section. We know it's mostly working on norepinephrine and dopamine transporters. Also, it's a useful medication for reversing sexual dysfunctions. We talked about it adds that noradrenergic tone to a system that is more favored towards serotonin, which can sometimes facilitate sexual response. Also useful for if you're looking for kind of 2-for-1s, looking at things like low energy and smoking cessation. So your doses for augmentation are the same as they are for monotherapy, usually 150 to 450 milligrams a day. Buspirone, it's sort of a funny med. This is a med that came out way back in like 1983, I think, for as an alternative to benzodiazepines. So it works on serotonin 1A, and it's a partial agonist. And so, it doesn't work as a PRN like a benzodiazepine does, but it was marketed as an anxiolytic. And so my experience with this clinically is that I wouldn't call it a nothing burger, but I don't have a lot of enthusiasm for it. When it has worked for me, it's usually In higher doses, so typically, sort of 45 to 90 milligrams, not the like 5 milligrams TID that a lot of people get started on. I also find that it works better for people that have not had benzodiazepines. So if you've had a benzo, or if you think of this as a PRN medication, you're going to be disappointed. But for somebody who has never had a benzodiazepine, this is a reasonable thing to try. There is some data that it also helps with sexual dysfunction, particularly in female patients. If it does work, the data set is fairly small, but if it does work, it typically works fairly quickly within a couple of weeks. So if you are going to try to augment somebody for sexual dysfunction caused by by SSRIs, then you should know within a couple of 3 weeks if it's helpful or not. So you're not keeping somebody on medication for a long period of time. But the main indication for this drug is generalized anxiety disorder, not for panic disorder. So your SNRIs, serotonin norepinephrine reuptake inhibitors, this is venlafaxine, duloxetine, desvenlafaxine, and levomenalcipran. So venlafaxine also has been around for quite some time. Like I said earlier, it's an SSRI up until you get into the higher doses. Duloxetine works on serotonin and norepinephrine transporters at all doses. Desvenlafaxine is really nothing new. It is the metabolite of venlafaxine, as you well know at this point. And levomenalcipran is the newest one on the block, but a decade or so old now. So it's the left enantiomer of menalcipran. Menalcipran is also available. It has an FDA indication for fibromyalgia, which kind of points to how these medications can sometimes be used in neuropathic pain syndromes. SNRIs, the main thing I want you to take away from this is venlafaxine. You really only want to use that in patients that are aware that they need to take the medication every day. I had a friend years ago who forgot to pick up his venlafaxine from the pharmacy on Friday before they closed, and by Sunday he was throwing up continuously and thought he had food poisoning and went to the emergency room for IV fluids. So, not a good time. It's not life-threatening, but it's certainly no fun and can be avoided with maintaining regular dosing. But, we all forget to take medications sometimes. And so it's just something you want to talk to your patients about if you're going to start them on this. So let's talk a little more about lithium. So lithium, we're going to talk about more in greater depth when we get to second messenger modifiers, also known as mood stabilizers. The reasons why this works as an augmentation to antidepressants isn't really well understood. It might increase the availability of serotonin. Not totally sure. Um, Pause for a moment. The joys of working from home. My apologies for my dog barking in the background at the Amazon guy. So when you add lithium for antidepressant augmentation, you can often get away with a much lower dose than we would use in bipolar disorder. But you do still need to follow the same precautions that you would when using this in bipolar disorder. So we still need to do a lithium level of 5 days to a week after starting the medication, and we need to do regular blood draws to make sure that we're keeping it within a therapeutic range and that we're protecting the kidneys and the thyroid. So that sometimes those lab requirements are often one of the reasons why people don't end up using the lithium. And also, I think with the increasing use of second generation antipsychotics, or also known as dopamine serotonin blockers, in the treatment of depression, or at least as an augmentation for depression, we're seeing less lithium augmentation. But I do want to just make sure this is in your armamentarium because it can be a very useful medication. And there is some evidence. It's more strong evidence in patients with bipolar disorder that lithium has a protective effect against suicide. And so that would be another argument for starting lithium in a patient with depression who has some suicidal ideation. So Cytomel T3 is something that can be used also. This is used in STAR-D. This can be used even if somebody has a normal thyroid. I wouldn't use it if somebody who had hyperthyroidism, but definitely if somebody is in normal thyroid range, it would be reasonable to use T3 and reasonable doses. So around 45 milligrams was what was the average dose that got people better in STAR-D. And this is usually a pretty well tolerated treatment. And you're going to want to keep track of TSH if somebody is on Cytomel, of course. Now, the tricyclics are an interesting class of medications. So, weird anomaly of nomenclature in pharmacology. So, normally we group meds by mechanism of action. Tricyclics, for whatever quirky reason, are grouped by their structure, not by their mechanism, because if they were grouped by mechanism, we would call them serotonin and norepinephrine reuptake inhibitors, because that's what they are. That's what they do functionally, but they're called tricyclics because they have this three-ring structure similar to chlorpromazine. So chlorpromazine is thorazine, and there's an attempt to kind of improve upon it. And so back in the 1950s, I believe, they made imipramine, which has a similar structure. And it didn't really work for psychosis, but it was tried on patients with depression and found that there was some improvement in mood. There's even some argument that maybe what they were actually doing was inducing mania in some patients that were probably bipolar, but our sort of way of thinking about psychiatric diagnosis was a little bit different then. And so it comes out in 1958 with the term antidepressant hadn't been coined yet. They called it a thymoleptic, which is a kind of a mouthful, but thymo meaning, like euthymic, right? So something that would address depressed mood. And then clomipramine rather comes out later. That's an Afrinil, and then amitriptyline comes out, and amitriptylines. So nortriptyline is to Pristiq what amitriptyline is to venlafaxine. So it's the metabolite of the drug. And in the case of nortriptyline, it has fewer side effects, fewer off-target receptor activity than amitriptyline, which tends to hit a lot of receptors and causes a lot of side effects. We still see a lot of nortriptyline used usually in primary care for neuropathic pain syndromes such as fibromyalgia, sometimes used as a prophylaxis for migraine headaches. And it's important to know that while we may not use these medications that much in psychiatry anymore, they're still effective medications. There are some things that we have to be thoughtful about, and I'll talk about those. But for some conditions such as OCD, clomipramine, which is very serotonergic, is still considered kind of a gold standard treatment for OCD. So as I mentioned, they are SRIs and NRIs. They're not so selective, so that first S is a little misleading. But let's take a look at some of their receptor activity and realize that this is not a monolithic group of medications. You can think of them on a spectrum. So again, looking at these Ki values. So what does it do? How much does it inhibit the serotonin and the noradrenergic receptors, respectively? So let's take a look at some of that clomipramine. As I said, very serotonergic, very low Ki for the serotonin transporter, compared to the norepinephrine transporter. Not that potent on the norepinephrine transporter. So we'd call that a more serotonergic tricyclic antidepressant. Let's take a look at disipramine to contrast that. So disipramine, very potent on the norepinephrine transporter, but not so much on the serotonin transporter. So we put that all the way to the noradrenergic side of things. So even though both these medications are considered tricyclic antidepressants, because structurally, so you can see on the top right here, they have that three-ring structure. Functionally, they have very different effects at the transporter. So then nortriptyline kind of right there in the middle there, a little more on the noradrenergic side. So about a 10-to-1 ratio of inhibition of the noradrenergic transporter compared to the serotonergic transporter. So that's why we use this in conditions of chronic pain. And then we look at side effects by looking at what other receptors do they hit. So looking here at histamine, at noradrenergic alpha-1 receptors, at acetylcholine muscarinic receptors, and then serotonin 2A receptors. So looking at something like doxepin, very sedating medication because it's quite antihistaminic. And this is why we use this medication now in very small doses, like 10 milligrams or less for sleep. Because it has this strong antihistamine response. Amitriptyline, quite potent on the acetylcholine muscarinic receptors. So this is why we say it has a lot of anticholinergic side effects, such as dry mouth and blurry vision. Also hits the alpha 1 norepinephrine receptor, which is going to cause orthostatic hypotension. So we might see both sedation and sometimes dizziness upon standing when we are blocking that noradrenergic alpha 1 receptor. Disipramine, not very anticholinergic. So that's one of the things that makes it a nice kind of more tolerable medication. And I actually like disipramine. It's one of my favorite tricyclic antidepressants. So nortriptyline was the drug that they used in STAR-D because it's kind of right there in the middle in terms of its receptor activity. Also just a commonly used medication. So we see low doses of nortriptyline, like 10 to 50 milligrams used in the treatment of chronic pain, but the antidepressant doses that start at about 50 milligrams, to pain docs, they see 50 milligrams as like a high dose of nortriptyline. To me, that's like a low starting dose, and up to 200 milligrams for its antidepressant effects. And STAR-D, you saw about 20% of people showing some response, a little over 10% going into remission. And so a situation where you might use nortriptyline is you get a patient that comes into you that says, I have fibromyalgia and I take 40 milligrams of nortriptyline a day and it works great for that, but I also have depression. So I might say, hey, this medication you're already taking that you're probably already tolerating pretty well, otherwise you wouldn't be on it, could be pushed to treat your depression as well as your fibromyalgia. Would you be open to trying that? And a lot of people like to be on fewer drugs than more drugs. And so that's certainly a reasonable thing to consider trying. Now, the downsides of tricyclics have to do with these off-target or other neurotransmitters that they happen to affect. So in the case of some of the tricyclics, the muscarinic acetylcholine receptors are going to cause those classic anticholinergic side effects. Your noradrenergic alpha 1 blockade is going to cause orthostasis and sedation, dizziness, drowsiness, and weight gain from histamine receptors. And then this real concern that I mentioned earlier, which is because these can also block sodium channels in cardiac cells, they can lead to these lethal arrhythmias such as Torsades de Ponce, which can go into VFib. So that's the concern with these medications, is because they can block those receptors. If you have somebody who has a propensity towards suicidal acts, you want to be really careful giving them a tricyclic antidepressant prescription, because a month's worth of this medication in many cases is enough to be lethal. So if we're going to start a tricyclic, we want to think about the heart. We want to think about taking a cardiac history, just asking somebody if they've had arrhythmias, they have any, if they know that they have a long QT syndrome or have had bundle branch blocks, any kind of electrical conductivity issues we want to be thinking carefully about. And it's reasonable to get an EKG before you start a tricyclic. They're simple and cheap, and just making sure that somebody doesn't have a long QT syndrome to begin with. We also want to think about if they're on other anticholinergic medications. So because this is likely going to have its own anticholinergic effects, if they're on something like ditropan, we're going to make that the effects of that maybe even worse. So we want to be careful not putting too much anticholinergic load onto our patients, especially our older patients, because that has the potential for causing an anticholinergic delirium or worsening cognitive impairments. Most tricyclics will start at 25 milligrams. That's kind of a nice way to remember it. And you're going to go up every 3 or 4 days as they're tolerated. Again, there's going to be that delay between starting the medication and seeing the therapeutic effects, but you'll see side effects first. Mirtazapine. This is kind of a back pocket medication for me. I found this very useful over the years. This is part of what you might call an atypical antidepressant. So it includes trazodone and nifazodone. The thing I like about this is because it has these sedating side effects and because it has these appetite stimulating effects, this can be really helpful for somebody who has a kind of anergic, that is another word for saying sort of fatigue, tired, depression, that isn't sleeping very well, that isn't eating very well. So some people get quite short of appetite when they have depression, and so mirtazapine can be quite useful for that. And it has some interesting kind of complex sort of mechanism of action, which we can just kind of go over quickly here. So it's an antagonist at norepinephrine alpha 2 receptors. I'll explain why that matters in a minute. It blocks histamine receptors. It blocks serotonin 2A, 2C, and 3 receptors, but it's not a reuptake inhibitor. So unlike the SSRIs, it actually doesn't have this monoamine reuptake inhibition like a fluoxetine or a bupropion, something like that. Also doesn't hit the muscarinic receptors, so it doesn't have those anticholinergic side effects. So what this is doing is it's blocking the norepinephrine alpha 2 autoreceptors. And so autoreceptors on norepinephrine neurons and what are called heteroreceptors on serotonergic neurons. Why does that matter? Well, remember the autoreceptors are kind of like that thermostat, if you will. So when they give a feedback to the presynaptic neuron. Once they get enough, in this case, norepinephrine floating around, plugging into the autoreceptor, it tells the presynaptic terminal, hey, you can stop releasing norepinephrine now. So by blocking that, it's like putting an insulation blanket over the thermostat. The thermostat's not going to know what temperature the room is, and the heater is going to keep making heat. And so what that means in this case is that with that mirtazapine molecule sitting on that norepinephrine autoreceptor, then norepinephrine just keeps getting pumped out. So we get more norepinephrine in the synapse, which has an association with antidepressant response, of course. And then there's also these alpha 2 receptors that are on the somatic dendritic receptors on serotonin neurons. So not getting too in the weeds on this, but essentially what's going to happen is this is going to cause more serotonin to be released. But we're also going to block postsynaptic serotonin receptors, so particularly serotonin 2A and 2C. And this is so blocking serotonin 2A is similar to what the atypical antipsychotics do, second generation antipsychotics. And serotonin 2C blockade is probably what is the cause of, in addition to histamine blockade, of appetite stimulation with this drug. So things that block serotonin 2C tend to be associated with appetite stimulation. Now, one of the nice things about mirtazapine, it's kind of like it has ondansetron built into it. So because it is a serotonin 3 antagonist, just like ondansetron, you don't get that sort of nausea effect that you sometimes get with other medications. So I really like this medication for people that say, oh, geez, every time I take an antidepressant, I get nauseated, I feel sick. This can sometimes be a real back pocket drug to use. I want to touch on MAOIs. This is kind of, these have been around for a long time because they were first discovered in the 1950s. And it turns out that iproniazid, which was a drug, an anti-tubercular drug. So remembering back in the 50s, tuberculosis was pretty widespread. And then we had these large tuberculosis asylums, actually. And one of the drugs that was being used was iproniazid. And as the story goes, you had people that were kind of not feeling so great. They were stuck in these asylums for months at a time, recovering from TB. This drug iproniazid comes out, and people were dancing in the hallways, as it was said. Not sure if that's totally true, but it was a sort of accidental finding that monoamine oxidase inhibitors, which iproniazid happens to be one, reduce the breakdown of monoamine, so serotonin, norepinephrine, dopamine. And those MAOs, those enzymes are found on the mitochondria, so inside the cell. Sorry, folks, for the disruption. Deal with my barky dog. So these enzymes, these monoamine oxidases, are actually found on mitochondria inside the presynaptic cells. So once that reuptake pump takes the neurotransmitter back up into the presynaptic terminal, it's either repackaged for re-release or it's broken down or catabolized. by these enzymes. And so you can imagine by inhibiting them, that increases the net amount of these neurotransmitters that are available for neurotransmission. And so we have two groups of MAOIs. So we have the non-selective, and we have the ones that are selective. And so, or what are sometimes called MAOI Bs. So selegiline is sometimes used in the treatment of Parkinson's disease. So not used a whole lot. Um, not commonly used at this point. And there's this idea of atypical depression, kind of an older idea of a subtype of depression, which is that MAOIs were more useful for. It was the last line of treatment in STAR-D, and so had pretty minimal response. There's some people that think we should probably use MAOIs more frequently, but the main reason why we don't is because they don't play well with other meds and they don't play well with a lot of foods. So the problem is that MAO also breaks down the amino acid tyramine. Tyramine is found in a lot of different foods. So it's found in sort of aged cheeses and smoked meats. It's found in Chianti wine. It's found in certain beers. It's found in certain fruits and vegetables like avocados and bananas. And also, so when you don't break down tyramine, then it becomes a direct pressor. It actually causes blood pressure to increase. And the other thing that this is a problem with is with other drugs that are sympathomimetic, which is another way of saying they increase activity of the sympathetic nervous system. So common things such as stimulants and some decongestants like pseudoephedrine. And also anything that's increasing the amount of monoamines already. So SSRIs, tricyclics, it's this is also, just as an aside, the psychedelic sort of admixture tea known as ayahuasca is two different plants, one of which contains dimethyltryptamine, which is the psychedelic part, psychoactive part, and another that contains harmaline alkaloids, which is an MAO, naturally occurring MAO inhibitor. And so this is the reason why if somebody's going to ingest ayahuasca, it's really important that they not be on something like an SSRI or a tricyclic antidepressant because they can get into serotonin syndrome. And so because of the complexity of using these medications, then there's these foods you have to avoid, and there are these drugs you have to avoid, because if you don't, you can potentiate a hypertensive crisis. They've sort of fallen out of favor. How should you do this? If you should do this, the first thing you're going to have to do is wash out any serotonergic drug. So if somebody is on a regular antidepressant like a escitalopram or a paroxetine, they're going to need to wash out for 5 half-lives. And for fluoxetine, that's a real long time. It's 5 weeks. So they would need to wash that drug out of their system entirely. So 5 half-lives before you start the MAOI. Okay. If you don't, you can get into serotonin syndrome. And serotonin syndrome is characterized by 3 different clusters of symptoms. So you get autonomic changes. So that can look like hypertension, tachycardia, sweating. You can get cognitive changes, which is you're going to have somebody having confusion, delirium, and somatic changes. They're going to be twitchy. They're going to have hyperreflexia. This can be really dangerous, okay? Particularly the hyperthermia aspects of it. People can get into a malignant hyperthermia. We've seen this in some sort of harm reduction spaces where people have ingested a lot of a serotonergic psychedelic like MDMA, or a combination of different medications can get into a malignant hyperthermia, which can be quite dangerous, even life-threatening. And so this is really an emergency. This is something that needs to be treated in a hospital, not in your clinic. Oftentimes people need to be admitted into the ICU. They're sometimes given a drug called cyproheptadate, which technically is an antihistamine, but has this fairly potent serotonin receptor blocking activity. And so it really is a medical emergency should you see this. So, I joke that MAOIs now exist to populate boards questions because about only 1 in 5,000 antidepressant prescriptions is for an MAO inhibitor. But, they are an interesting drug that kind of hangs out in the background. I've heard of some attempts to kind of rehabilitate them. I'm not sure where those will go, but, something definitely kind of keep your eye on. And there's been a few new drugs that have come out since STAR-D that are specifically antidepressants. So vilazodone is known as Vybrid. This is a combination of a serotonin reuptake inhibitor with also serotonin 1A partial agonism. So it's kind of like taking an SSRI and adding buspirone to it. And vortioxetine is also a serotonin reuptake inhibitor, but also has direct agonism on several receptor types. So antagonism, sorry, on serotonin 3, which makes it easier on the gut, and also serotonin 7 receptors. It's an antagonist, which is thought to have some improvement on cognition. At least that's what the sort of pitch is. And so, these have been vortioxetine has been sold as helping to improve cognition, and that would be its advantage. It's still a branded medication, so it's still fairly expensive. The Star D has a lot of challenges. I mean, obviously it's old, and it doesn't include some of these newer medications like vortioxetine. It was before we got into augmenting antidepressant medications with dopamine blocking medications like aripiprazole, or adding second message modifiers like lamotrigine or lithium. I mean, it included lithium, but lamotrigine can also be used as a means of modifying or augmenting antidepressant response. Didn't have an arm for ECT. TMS was still fairly new 20 years ago. Certainly didn't have ketamine or esketamine. I'm going to post an article. I'll put an article up in the website where you can take a look at some discussion about where ketamine and esketamine should fall into that. And then our final topic, what about psilocybin and MDMA, which are also have an effect of being either direct or indirect serotonin agonists. So our last section, we'll talk about those two areas of new drug discovery.